Good afternoon. Welcome to our presentation this afternoon, the pathophysiology of diabetes. I would like to acknowledge the lands on which we're meeting today, the Wiradjuri people, and pay my respects to elders past, present and emerging. Thank you all for joining us today. Before we begin, I would like to do a little bit of housekeeping. Today is a 30-minute presentation with 15 minutes for question time. Myself, Anne Burns, and my colleague Hayden Welsh from the PHN will be moderating this presentation. At the end of the presentation, there will be a short evaluation form, which you can use your phone to scan the QR code to complete the evaluation. If you would like, Irene has asked if you're happy to turn your cameras on during the presentation so she can interact with you during question time. But of course, if you do not wish to, you don't have to turn your camera on. Okay, so I'll introduce Irene. She is a highly experienced diabetes nurse practitioner, educator and clinician with more than 30 years of nursing experience. She has extensive expertise in diabetes management across hospital, community, aged care and palliative care settings, and has delivered education to nurses, GPs, allied health professionals and other healthcare providers throughout Australia. Irene is passionate about improving diabetes knowledge and helping health professionals deliver safe, evidence-based care through practical education and training. So we welcome Irene and I will hand over to her.
Hi.
Thank you.
Well, thank you. Hi, everyone. I'm Irene, and so we're going to just talk with, this is the first of 4 sessions about diabetes, and we're trying to focus it into the aged care setting. And the most important thing, I think, is to understand what diabetes is. So when you understand the disease, it's easier to manage the disease. So today is about what is diabetes, the differences, which is very important between type 1 and 2. They're 2 different diseases. And testing blood glucose levels, doing randoms is really useless. We need them done at specific times. And the correct technique on how to do that. So we're going to talk about all things diabetes. I've just put quite a bit of information here so you can read it in the background, but we're going to mainly focus on type 1 and type 2 because gestational diabetes I don't think is relevant for your population, and impaired glucose tolerance we don't really need to worry about. So just firstly, in the population, the incidence of diabetes in Australia, currently 6.6% of our population has diabetes, and a further 16.7% have a glucose intolerance, or what we call pre-diabetes. That accounts to over a quarter of the population have some form of glucose intolerance, and it's rising in prevalence, not just Australia-wide, but worldwide. So these are more stats on just people with diabetes in Australia. So 87% of all diabetes have type 2 diabetes in Australia, 9% have type 1. And that's very equivalent to world standards where 10% of diabetics have type 1 and 90% have type 2. And this is a really interesting slide. I love using this slide. This was made in 1995 by the International Diabetes Federation on the prediction of diabetes in the world. So in 1995, we had about 118 million people diagnosed with diabetes, and they predicted an increase of 87% by 2010. And they got that very wrong because we're up to 415 million, and now that's predicted to be over 645 million shortly. So it's definitely increasing in prevalence. It's costing us a lot of money. And the good news about that is that all the drug companies are saying, woohoo, there's a market, because there's a prevalence increase. So the technology in diabetes is booming. So continuous glucose monitoring, insulin pumps, the new style of insulins, then the injectables like the GLP-1s, your Ozempic and your Mounjaros and your Wegovy, which are amazing. That's all coming, and you guys have to manage these patients. And so you need to understand how this technology works if you have a patient with it on. So the cost of diabetes to Australia is quite significant at about 17.9 billion. The older we get, the higher the incidence of diabetes. 14% of Australians aged over 75 are living with diabetes, and 1 in 5 people at 85 live with type 2 diabetes. and 1 in 4 patients in residential aged care facilities have diabetes. So a quarter of your patients, you have to manage their diabetes. We speak a lot about carbohydrates and diabetes, and we speak about diet in one of the future sessions. Carbohydrates break down to glucose, and insulin is what we need to get glucose into cells. And we're going to talk about type 1 and type 2 diabetes today. All right, so the body is made up of billions of cells, trillions of cells, which divide, and they hand all that genetic information to the daughter cells. The only way a cell can do that is glucose. Glucose is what feeds your Krebs cycle. Glucose is the energy the cell needs to reproduce, and this is why we eat food. So you eat your food's digested, the glucose, the sugars are released into the bloodstream. Now the sugar can't get into the cell without the hormone insulin. Insulin's made in your pancreas. It's a gland that sits just here in the middle and is made from beta cells. And when you are born, you're born with about 1 million beta cells. Beta cells don't reproduce. Once they're dead, they're gone. But we have enough to last a lifetime. So you eat your food, your sugars are released, body makes an equal amount of insulin. Insulin grabs hold of the sugar and it grabs hold of the cell. We call it the key. The cell has the energy to divide. We go on living all as well. So in diabetes, for many reasons, we do not make enough insulin. So you eat your food, your sugars are released, but let's say you can only make this much insulin. So this insulin molecule will grab hold of the sugar, taking it from the bloodstream to the cells. These remaining sugars that don't have insulin will stay in your bloodstream. Now, too much sugar in your blood, it is a poison. It is toxic. First take-home message. And so blood travels throughout our body, the sugar travels in the blood and it hits our kidneys. And our kidneys' job is to filter the blood. So blood goes into the kidneys, it filters it, puts all the good things back into the bloodstream, and the kidneys dump all the bad stuff out of the body through the urine. So all this excess sugar comes into the kidneys. It says, well, you're a poison, I've got to get rid of you. Now, sugar in your blood, it's quite a large molecule. So for your kidneys to be able to dump the sugar out through the urine, it needs to dilute it. So when your blood sugars are high, your kidneys start pulling fluid from your bloodstream to dilute that sugar so we can dump it out the body through the urine. So as the kidneys keep pulling fluid from the bloodstream, they're dehydrating us. So the symptoms are dehydration. You're thirsty. You've got a dry mouth, dry skin. You're hot. You're flushed. You're tired. And what's happening as we keep trying to dump that sugar out, we're going to the toilet more frequently. So they're waking up in the middle of the night to go to the toilet 10 times. And then they're at risk of falls, right? So when you have high sugars and they're having to go to the loo, they're more at risk of falls. So they're the symptoms of diabetes: dehydration, thirst, tired, lethargy, dry mouth, and they're going to the toilet frequently. Now, the long-term complications happen. Sugar is sticky, and sugar deposits inside your blood vessels. And after many years of having diabetes and a bit of sugar here and a bit of sugar there, your blood vessel goes from that big to that big. And if your blood vessel blocks in your brain, you'll have a stroke. And if the blood vessel blocks in your eyes, you'll go blind. The blood vessel blocks in your heart, you have a heart attack. In your kidneys, in your feet, and the list goes on and on. And in Australia, the main cause of blindness is diabetes. In Australia, the main cause of renal failure is diabetes. In Australia, the main cause of amputations is diabetes. And we can't quite say the same for heart attack or stroke because of how we collect statistics, basically. Because if you died now of a heart attack, on your death certificate, it says cause of death, heart attack. But what caused you to have your heart attack? What caused your blood vessels to block up? Yes, you know, there are many factors, but diabetes is one of the predominant risk factors for cardiovascular disease. So it is in all the patients that you ever look after, anyone with diabetes, we need to keep your blood glucose levels within normal control, as near to normal as we possibly can, to prevent the symptoms, so they're not dehydrated, so they're not going to the toilet frequently, and they feel comfortable, and to prevent disease or progression of disease. So we need normal glycemia. Now, a non-diabetic walks around with an average blood sugar of 5, and an average blood sugar of 5 is equivalent to 2 teaspoons of sugar in your whole body. So when your patient has a blood sugar of 15, that's not okay. That is 3 times the amount. That's 6 teaspoons of sugar in their bloodstream, causing the symptoms and further complicating their risk factors. So we really do need good control. Obviously, in the elderly population, we do allow a bit of a buffer, especially in aged care. You know, if they're 20, I really am going to be strict on their glucose control. I want tight control because you want to live for another 60 odd years and we want to keep you healthy. When they're in their 70s, 80s, and they have a lot of comorbidities, my number one risk would be hypoglycemia. So I wouldn't want them to have a hypo because that leads them to a risk of falls. So we do loosen up the targets for the elderly to about 7 to 12. So there's a bit of buffer, especially on insulin or a medication that can lower glucose levels. So there's a bit of a buffer between hypoglycemia. So type 2 diabetes, as we discussed, is the major, is most diabetics you will see will have type 2, right? So type 2 diabetes is genetic. Yes, they have the gene for it, but it's to do more with lifestyle and inactivity. So if you look at your typical type 2 body, they have what we call the apple shape. So they have the larger abdomen and the smaller legs. If you look at your pear-shaped people, small abdomen and wide hips, the fat on your hips is actually harmless fat. So totally different fat to this visceral fat. This fat in the abdomen, that causes your blood pressure to go up. It causes your blood cholesterol to go up, and it causes your blood glucose levels to go up. So what happens with insulin resistance, which is what's happening with type 2 diabetes, this fat sits on the receptor site for insulin. So you know how I said insulin grabs hold of the sugar and it grabs hold of the cell? Well, there's a little receptor site on the cell, GLUT4, that's where insulin docks, opens the cell up, puts the glucose in. When we start putting on fat around here, that fat actually causes insulin resistance because it sits on and blocks that receptor site. So what happens in these people? Years before the diagnosis of diabetes, they eat their food, the sugars are released, they make enough insulin. Insulin grabs hold of the sugar, but it can't get into the cell. So there's too much sugar in my blood. The body's going to respond because that's a poison. So they're going to say, make more insulin. So the beta cells that you were born with start producing more and more insulin, start working a lot harder and dumping insulin into the bloodstream in an effort to get our blood sugars down, because we know if they're too high, we're going to get complications. And we can do that for many years. Those beta cells can work 2, 3, 4, 10 times harder. We can flood the bloodstream with insulin. But after many years of this, your beta cell mass reduces as they die off. And then all of a sudden your blood sugars go up. And that's when you turn up to the GP. I'm thirsty, I'm tired, I'm going to the toilet. You have diabetes, you have type 2 diabetes. And on diagnosis of type 2 diabetes, you've lost roughly 50% of your functioning beta cells. Now, insulin has another role. Insulin's job is to stimulate growth hormone. And when you have a lot of insulin circulating around your bloodstream, you are going to actually start to put on fat around the abdomen. So when you put on fat around the abdomen, it makes you more insulin resistant. And when you are more insulin resistant, you will make more insulin and put more insulin in your bloodstream, which makes you put on more fat, which makes you more resistant, which makes you make more insulin. And they get caught in this very vicious cycle and finding it really, really hard to lose weight. And this is where medications like metformin come in. Any drugs that work against insulin resistance as your first drug of choice does not cause hypoglycemia. It doesn't make them make insulin. It just gets rid of that resistance. So the insulin they make goes to where it has to go. But metformin is fully renally excreted, so we need to know what the eGFR is. We need to know what the kidneys are doing, because, and as just being older, we usually have some degree of renal impairment. So we need to monitor those kidneys to make sure the current dose is not going to cause them harm. Number one drug of choice for type 2 diabetes. We also give it to type 1 diabetics who are overweight, right? Because it helps lower their insulin requirements. So I need to get your blood sugars down. And so with type 2 diabetes, we normally say diet and exercise first, right? So instead of eating 3 huge meals a day, because you can't make this much insulin, eat 6 smaller meals a day because you can make this much insulin. So there's one thing. And don't drink Coke and soft drinks. There are 10 teaspoons of sugar in 1 can of soft drink. The World Health Organization recommends we have a maximum of 6 teaspoons of sugar a day in our diet. So 1 can of soft drinks will just spike them like crazy. Apple juice, orange juice, just as much sugar, except for Coke and lemonade has no nutritional value whatsoever. At least the juices have a little bit of vitamins in it. But be careful, because when we put patients on a clear fluid diet, and especially diabetics, and we give them apple juice, watch their sugar spike. So we try to withhold that and give them, we use that for hypos or sipping on if their glucose levels are a little bit low. So with type 2 diabetes, the first treatment is diet and exercise. And we look at carbohydrates. So us humans to be alive, we need protein, we need fat, and we need carbohydrates to live. We need protein because they build our muscles and repair damaged cells. We need fats, they make our hormones. Every cell in your body is lined in cholesterol. And we need carbohydrates because they break down to sugar. Sugar is the energy the cell needs to reproduce. Fat and protein don't break down to carbohydrates. So when it comes to a diabetic diet, we focus a lot on carbohydrates. And if you're an inpatient in hospital, we put you on a diabetic diet. It's exactly the same food as every other patient gets, but their carbohydrates are managed. So we give them 15 grams of carbohydrates as one exchange, and we'll say you can have 3 exchanges for breakfast, lunch, and dinner. So I know you're eating that much carbohydrates, I need to give you this much insulin. Because when their carbohydrate intake does this, yet the insulin dose stays the same, guess what their blood glucose levels are doing? And this is really difficult in aged care because there is no fixed diet. And I've been trying to get this done with dietitians and make it a bit more like a hospital. If they have diabetes, can we get them a set amount of carbohydrates? Because your GP isn't going to be adjusting doses every day based on what they're eating. We teach patients how to do that, but a lot of these patients don't know what to do. So they just eat. And your problem is you've given this much insulin. This day they've had that much to eat carbohydrate-wise, and this day they've had that much to eat carbohydrate-wise. So guess what their glucose levels are going to do? So really trying to get dietetics into nursing homes and aged care to work out a diet so their carbohydrate intake is consistent because the dosing of insulin we give them is consistent. So if you've got a patient with diabetes who's had it for many years and has learned to count carbohydrates, we give them then a ratio. So you have an insulin to carb ratio. For every exchange, you may need 3 units of insulin. So I'm having a lasagna with chips today, loaded in carbs. I may, I've had 6 exchanges, I need 18 units. Tomorrow I'm having a salad with steak, no carbohydrates whatsoever, and maybe 1 bread roll. So you're having 1 exchange, you need 3 units, right? So that is what's really is difficult to manage in aged care, and that's why a lot of their glucose levels fluctuate so much. So, and back to insulin resistance. We don't become overweight overnight, right? So let's say you're 20 and you weigh 70 kilos, perfect weight for your body size. And let's say you put on 1 kilo a year. 1 kilo a year, that's nothing. So at 20, you weigh 70. At 30, you weigh 80. At the age of 40, you weigh 90 kilos. At the age of 50, you weigh 100 kilos. So for many, many years, they've been overweight. For many years, they've had insulin resistance. For many years, their insulin levels have been too high. And this is where we're trying to target GPs. Don't just do a blood sugar because that will be normal. But if you did an insulin level, if it's through the roof, they haven't got diabetes yet, but we're burning their beta cells out, we're setting them on a trajectory to it. So we want to get that, we want to identify this pre-diabetes early to prevent progression to diabetes. And this is where diet and exercise comes in. And I quickly do want to mention exercise. The slides are later, so I'll just go through it. But with exercise means increase your heart rate, a little bit out of breath, and a light sweat. However you achieve it, I don't care. You can walk, you can run and swim, or you can vacuum. You can mow the lawns, you can wash your car. That is exercise. And for these guys walking around on their scooters or on their four-wheel walkers, that potentially is exercise if they get that heart rate up. When you are exercising, your muscles have stores of glucose in them, ready to go, glycogen. So when I go for a walk, my muscles utilize those stores of glucose for energy. When I stop walking, those muscles say, oh, now, all right, I've got to replace these stores now for the next time you exercise. Half an hour of exercise here for the next 10 to 15 hours, your muscles will be pulling sugar from your blood to replace those stores. So you could exercise at 9 in the morning and have a hypo at 1 in the morning. So when it comes to exercise, so if your patient's having a day pass and's out with the family and they've gone to a park or they've gone shopping, they've been much more active than normal, they potentially need either an insulin reduction, which is hard for you to do, or you're probably easier from your point of view is give them extra carbs, especially if they're lowering, and be vigilant on those glucose levels, because if they have been active, they're going to drop over 9. This is where we can get nocturnal hypoglycemia. And this is why you definitely want to be checking glucose levels at 2 o'clock in the morning. So that's insulin resistance. So type 2 diabetes, its majority is obesity and inactivity. And for your own family, for your own friends, move more and minimize the junk food. And that's just a little bit about too much insulin in our body. It causes this resistance and it's due to the fat. We spoke about the symptoms of diabetes, which is basically thirst, dehydration, drinking a lot, and weeing a lot. Exercise. So the more muscle mass you have, the more GLUT4 receptor sites you have. So GLUT4 receptor sites, insulin's receptor sites, are all over skeletal muscle. So when you have a lot of skeletal muscle, you are very insulin sensitive. When you have a lot of fat you become insulin resistant. So it's so important for our elderly patients to keep them as active as we possibly can, keep as much muscle mass as we can, because that makes them as insulin sensitive and less need for medications. So we really want to keep them moving, and you want to keep yourself moving and your family. That's just something about the different insulin receptor sites all over the place. The skeletal muscle is your main one. This is just really an interesting fact for metabolic syndrome. It's now pre-diabetes. So the definition by the International Diabetes Federation is we have central obesity, and it's very much dependent on your race. And you have either triglycerides that are greater than 1.7, very easy for us to have, reduced HDL, because high density lipoproteins, they are good fats. We want high HDLs, you know. And if you have low HDLs, that's bad. Or if you have raised blood pressure, 130 on 80 is actually what's recommended. Or if you have a fasting glucose level that is 5.6 or above. So a waist circumference that's larger, and any two of those, and you have pre-diabetes. And how much of our population will fall into that category right now? Just to let you know, so us to be alive, us humans need insulin in our bloodstream at all times, and we need sugar in our bloodstream at all times, and our body would like to keep it within certain parameters, homeostasis, it will regulate that. So my pancreas, a non-diabetic pancreas, will be secreting insulin in the background very lightly. We call it basal insulin. It just dribbles insulin into the background 24 hours a day. Depends on how much you weigh, how much fat you have, how active you are, how a skeletal muscle. But roughly half a unit of insulin per kilo of body weight per day, it's dribbling into the background. I eat a meal, my blood sugars go up. It makes a spurt of insulin to bring my blood sugars back down. And by 2 hours, I should be less than 7.8. And then it dribbles again. So this is what we call basal bolus. So the pancreas is secreting basal insulin constantly. I eat a meal, it makes a bolus amount, it brings me back down, it goes back to that background basal rate. I need another meal. So my pancreas will keep my blood sugars within a certain range. But even a non-diabetic, if I had a can of Coke, I would hit a blood sugar of about 15, 16 within 30 minutes an hour. But I am able to make that much insulin by 2 hours later, my blood sugar is down to less than 7.8. With such a big sugar spike, if you do it a lot, you'll find they crash and have a hypo, because this is the resistance. It's making them make so much more insulin. So, sorry, I wasn't going to put that in the GI of food. The glycemic index of food is just explaining that certain foods break down very quickly in our bloodstream, like a can of Coke, and certain foods take a while to break down. So if you had a pizza, for example, you know, your pizza is a pizza pastry base with sauce and cheese and meats and chickens and all that deliciousness on it. And I chew that and I eat it, and that sits in my stomach in a ball of goop. So my stomach's job is to break down the food into a liquid paste. So my stomach sends out acids, and it's just a little mechanical engine that breaks it down to a liquid paste. Then from there it moves into the small intestine. And in the small intestine, it's broken down further to the molecular state, and the glucose travels through the small intestine wall into the bloodstream. So if I had a yogurt, my stomach doesn't have to do a lot. It pretty much goes straight through and up into the bloodstream. So we call that a high GI. Whereas if I had pizza, that will sit in my stomach for 4 or 5 hours, right? And so it's a low glycemic index, because over that 4 hours, it's continuously dribbling glucose into the bloodstream. And this is where, even if you counted all your carbohydrates correctly, and you said that was 45 grams of carbohydrates, and you gave the direct amount of insulin, your insulin is absorbed straight away, but that pizza is sitting there for many hours. So this is where people will have a hypo here and will go high here. And that's the glycemic index, just to complicate diabetes even more. It is a very complicated disease. And, you know, you think, why are these things happening? Exercise lowers them. Certain foods will sit in their stomach for longer and won't be absorbed. Other foods will spike them quickly. Yet the insulin, which you get the same dose every day and has that predictable curve, all these other things make it unpredictable. And that's where we get problems with diabetes. So 85 to 90% of diabetes is treated with type 2 diabetes is treated with oral agents, but about more than 50% of them will go onto insulin at some stage. So managing type 2, we spoke about it. Lifestyle, keep them active, watch what they eat. Stop, if you can, the families from bringing in their lollies and their biscuits and their junk food. I know it's their right to eat it, but when you do that, you bring all these junk foods in, their blood sugars are going to go through the roof. And then the GP comes in, oh, he's really high all the time, I'll up his insulin. Then he's run out of those biscuits and he doesn't have them the next day and he's going to crash and hypo on you. And so having a look at diet and explaining to families, hey, instead of bringing in lollies and chocolates, can we bring in cheese and crackers, or can we bring in, foods that aren't going to raise their blood sugars quickly? And when you explain to them why, because I've done this to many families, they're very happy to comply because they love that their father, their mother, whoever. They didn't understand that was doing them harm. And if they've had long-standing diabetes on insulin, they like to have their hypo foods there, but then they like to also keep nibbling on those hypo foods. So it is hard, it is different, but try to monitor their glucose intake. That will help you a lot. All right, type 1 diabetes, totally different disease. Type 1 diabetes, again, it affects the beta cells, but it's an autoimmune disease. So we used to call it juvenile diabetes. It is mainly diagnosed in childhood, but I'm seeing it diagnosed much later. I've just had an 89-year-old man diagnosed with type 1 diabetes this year. So this poor guy's really set in his ways and he's struggling a lot. So type 1 diabetes, they have the gene, totally different gene to type 2. It's following an immune response to a virus or a bacterial infection. So post-COVID, we've had a lot of diagnosis, or a very, very stressful event. And so the gene, the stressful event, the immune response kicks in, and what happens? A little protein gets added to their beta cell. And your T cell, your main white blood cells, say, hey, beta cell, I don't recognize you. You don't belong here. I'll kill you off. So type 1 diabetes is where your own body destroys your beta cells. Once that destruction starts, we can't turn it off. So these guys classically present when they've lost in excess of 90% of their beta cells, and they're down to that last 10%. And these beta cells are working really, really, really hard to try and bring their blood sugars down. And then all of a sudden, these guys are tired, thirsty, losing weight, and going to the toilet frequently, have no energy, so they think, I'll have a can of Coke, I'll have an apple juice, that'll pep me up, which makes it even worse, right? So you could eat 10 Big Macs if you wanted to. You could flood your bloodstream with sugar, but if you haven't got insulin to get the sugar from the bloodstream to the cells, those cells are starving, and you're just weeing it out, right? Now, our body has worked over the years from cavemen to store fat as a source of energy, so that during famine, we could utilize our fat stores for energy. And today, we don't really have much famine. So what happens with a type 1 diabetic or a patient who's lost in excess of their beta cells, and those last remaining beta cells just can't make enough insulin? Their cells say there's not enough food coming, I'm starving, I'm going to die. And when we lose too many cells, we die. So we flick over our metabolism and we start using our fat as a source of energy. Now, when a fatty acid is metabolized in the liver, it's broken down into 3 components. 2 of them are sugars, they're given to the cells, and a leftover bit of fatty acid metabolism is called a ketone, and they're released into the bloodstream. Now, a ketone is an acid. And so another fatty acid is broken down, the sugars are given to the cells, another ketone, another acid is released into the bloodstream, and so on. And more sugars are given to the cells and another ketone. And as these ketones, as these acids accumulate in your bloodstream, it changes the pH of your blood, and the body doesn't like it very much. Now, in the presence of insulin, a ketone is reverted to a harmless substance. So, not a diabetic, I make insulin. Let's say I've got gastro for a week. I'm sick in bed, vomiting, diarrhea, can't eat. As long as I can drink, I can stay alive. And I'm drinking water. At the end of the week of no food or liquid intake, apart from water, I would have lost weight, right? I would have lost fat, would have lost some muscle, lost a lot of fluid, and I would have lost some weight. And if you check my blood for ketones, I will have starvation ketosis. I will have ketones under 1. But my body's utilized my fat as energy, the glucose is given to the cells, the ketones released into the bloodstream, but I make insulin. So my beta cells are still making insulin. I have insulin in my bloodstream that converts that ketone to a harmless substance. With a type 1 diabetic who makes no insulin, or we withhold their long-term insulin, what happens, there's no insulin, those acids accumulate in the bloodstream and accumulate and accumulate, and that's how we get DKA, diabetic ketoacidosis. Their bloods turn to acid because of ketones, because they have type 1. Most type 2 diabetics make enough insulin to prevent ketoacidosis, unless they're a very long-standing type 2 diabetic who have a very small beta cell mass left. I have seen it, and it's usually post like a heart attack or a stroke or a major event. But DKA is very rare in type 2s. If you have a type 1 patient and their blood sugars are high and they don't look well, you have to do a blood ketone test. Right? That's what helps you define, is this person going to hospital or is this person staying here, we're just managing hypoglycemia? So diabetic ketoacidosis has about a 10% death rate. So it still kills a lot of people. We need to be on it. And their sugars don't necessarily have to be very high, because if they're very strict and they have a UTI, they can go into sepsis, they'll go into DKA if they have type 1 diabetes. So having the ability to check glucose and ketone levels, blood, not urine. Urine is a reservoir that's telling me what happened hours ago. I need to know what it is now. And you do blood glucose and blood ketones, and all your hospices and homes and everything must have their own glucose meter and ketone meter. And I've gone to quite a few nursing homes who are using patient meters on all the patients, which you cannot do. You have your own blood pressure meter, you have your own pulse oximeter, and you have your own glucose and ketone meter. And that's part of the necessary equipment you need in that nursing home to diagnose. And you need one that we know is accurate, that takes hematocrit and a whole lot of other medications into consideration. These home blood glucose meters don't have that. So type 1 diabetes is an autoimmune disease. Basically, think of them, they make zero insulin. So they are insulin dependent. We used to call them the old IDEMs, insulin dependent diabetes mellitus, whereas type 2s were non-insulin dependent diabetes mellitus, but they could have been NIDMs IR, insulin requiring. It's stupid. If you see that terminology, the writer, the author doesn't understand diabetes. It's type 1, they're on insulin, end of story. All this medication for insulin resistance that works on beta cells is irrelevant. They have no beta cell mass to stimulate. Type 2 diabetes, we use diet, exercise, medications, and insulin. And we put a lot of patients on insulin because we know that's how we're going to get the best management. So I just wanted to show you, this is the structure of insulin. So this is the same molecule in NovaRapid, in Fiasp, in Humalog, in Apidra, in Optishlan, in Toujeo. It's exactly the same insulin molecule, but they're bound in proteins differently. So the protein of insulin in, say, NovaRapid or Humalog or Fiasp is bound very loosely, so it's released quickly and it's worn off in 4 hours. The protein around something like Optishlan or Toujeo is bound very tightly. It's a low pH, so it releases for a whole 24 hours. But at the end of the day, it's exactly the same insulin molecule. Just remember, just because they have ketones doesn't mean they have DKA. They have ketosis, right? If the ketone level is greater than 1, red flag, alarm bell should be sounding, and we'll be monitoring that patient. And if there's vomiting or diarrhea, they've got cramping and unwell, then the only way we can do a pH is in a hospital setting. We're going to give them fluids. You're going to drink water unless they're fluid restricted, and you're going to call an ambulance if the ketones are over 1, or you call for a review. I'm going to go on. So LADA, it's latent autoimmune diabetes in adulthood. If you just hear that terminology, it is type 1 diabetes. It's just diagnosed later. And in childhood, from the beginning of diagnosis to they're being able to kill off that last remaining beta cell takes about a year. And we call this a honeymoon period. In LADAs, they can honeymoon for 4 or 5 years, and they classically get misdiagnosed as type 2s first. They just fail treatment until they come to us and we say, you've got type 1. And we do GAD antibodies and insulin islet cell antibodies. And MODY is, don't even worry about MODY. It's maturity onset diabetes of the young, which is a genetic predisposition as well. And it affects their glucose levels. Or you want to know, do I have a type 1? Do I have a type 2? Because your treatment is you will never omit insulin in a type 1, and you'll be worried about ketones. So a glucose tolerance test is how we used to manage diabetes, how we diagnosed it, because diagnosis is important. We'd have them fasting, and if their blood sugars were less than 6, that's normal. And if your fasting blood sugar is greater than 7.8, you have, if your fasting is greater than 11, if your fasting is greater than 7, you have diabetes. If your fasting is between the 2, you have pre-diabetes. We then get you to drink 75 grams of a glucose drink, and you sit down for 2 hours. So we've shot your blood sugars up. You should have made enough insulin that by 2 hours, your blood sugar was less than 7.8. If it was, you're normal. If it was greater than 11.1, then you have diabetes. And if it's between the 2, again, you have impaired glucose tolerance. We now use HbA1c. This is a very important tool for you to monitor your glucose, your patients. So HbA1c is a tool we use to diagnose diabetes and how well it's being managed. So it looks at your red blood cells, your hemoglobin, your HB, and it sees how much sugar has been glycated, stuck to the outside of it. Red blood cells live for about 3 months. So this test looks at the oldest red blood cells that have been alive for 3 months, and it finds out your average blood sugar. So it will, if your average in the last 3 months is between 5 and 15, it will say the average was 10. You had some higher, you had some lower, but that was your average. Now, a HbA1c is measured in a percentage. And if I said your blood sugar is 5, that's measured in millimole per litre. So a HbA1c of 6.5% does not mean you had an average blood sugar of 6.5. To equate that to millimole per litre, you double it and take away 4. So 13 minus 4 is an average blood sugar of 9. 6.5% is the criteria we use to diagnose diabetes on a HbA1c. And if it's greater than 6%, you have pre-diabetes. So it is a tool. It's not perfect. It's like BMI. It's a tool. If I had a 6-foot tall weightlifter full of muscle, no fat, if I did the BMI on him, he'd be obese, right? But he's not. So the HbA1c has faults because if you have a lot of hypos, it drops your average. And I had a kid in my room not long ago. I uploaded his CGM data and his blood sugars literally every day were 2 to 20. He overcorrected his hypos and he'd overcorrect his highs. And I said, dude, we've got to change everything. We've got to back off. You're killing yourself. And then he smirked at me. I said, what's wrong? He said, I saw my GP yesterday. He literally gave him a pat on the back because his HbA1c was 7%. So if they're having a lot of hypos, it's flawed. For every percentage, we drop the HbA1c, the deaths, the microvascular, macrovascular complications are greatly reduced. So it is important we monitor that. Just quickly, glucose monitoring. Diabetes mellitus literally means sweet urine. And in the olden days, to actually diagnose patients with diabetes, they would drink, the JMO's job of the day was to taste the patient's first urine in the morning, and if it was sweet, that's how you were diagnosed. Then they used sheep's wool and stannous chloride, and if it went black, we'd know you had sugar in it. And then, I don't know, for the older nurses, we used to have these Clini sticks, which is pretty much like you do a UA. You looked at the colour. Then the Ames meter actually gave you a number where you were on that sugar scale. And then these came out in the 80s. You had to have a big drop of blood. These were the first blood glucose monitors. You had to wipe the blood off in a minute, put it back in, and 2 minutes later you got a reading. And nowadays there's heaps of meters out there. They've passed TGA. They're all accurate. So I don't care what meter they use. That's a guide, and that's what they use. But for you, you need a proper authorized meter. Testing time. So blood sugars go all over the place, up and down throughout the day. So if I did a blood sugar on you and it said you're 5, what does that mean? Are you 5 on the way up? You're going to be 20 in an hour. Are you 5 on the way down? You're going to be 1 in an hour, right? You've just got a point on that curve somewhere. So what we want to grab is the lowest, the peaks and the troughs, and then we know how to manage the diabetes. So the most important blood sugar is that fasting, the first one of the day, when they wake up first thing. That's the baseline. How much sugar is in my blood without the effect of glucose on it, because hopefully they haven't eaten for 8 or 10 hours. That potentially should be less than 6. For your residents, less than 7. I then want to know, well, how high do you go? And so 2 hours after the beginning of the meal, we're going to check. So they have the first bite at 12. You need to check at 2, right? And then if they're greater than 8, or for these patients 12, if they're too high, we know we have to increase their insulin, or potentially that day they had cake or they had something really high carb. So pre and post meals is good. And if you can only do 2, you do a before bed and you do a first thing in the morning. I went to bed here and I dropped to here. That's scary, because one day when you go to bed here, you'll have a massive hypo overnight. So in the hospitals, we routinely check that 2 o'clock in the morning. And for your type 1 patients is recommended, because sometimes patients drop and have a hypo and then they rebound a bit, and this is dangerous. So that'll be advised by the doctor. In general, glucose targets are between 4 and 8. If you were to go into a hospital, glucose targets are 5 to 10. And for the residential aged care, these guys are sick. That's why they're in that care. They have a lot of comorbidities. Again, don't want them anywhere near hypos. And we don't need really tight control, because I'm not really worried about their complications in 20 years' time. I'm just wanting to keep them stable and feeling good. So glucose levels of 7 to 12 is what's recommended. I've got, I'll send these all to you, Anne and Hayden. I've got a whole lot of leaflets and information from all around the world and Diabetes Australia about glucose management and all that in aged care, which are really good resources for you guys to use. So testing, if you're doing blood glucose testing, what is vitally important you test before the meal. And when I did audits on nursing homes, it's really frustrating, because you've got glucose levels on this system, insulin here, and then you've got other stuff here, and you've got to match it all up. So this was a nursing home I did in Penrith, which had 105 beds, and it had 1 RN on. And so blood sugars were done sometimes by the carers before breakfast on rising, sometimes during breakfast, sometimes after breakfast. And then the RN, by the time she got to the first, so a quarter of the patients, she had something like 20 patients on insulin. She got to the first one before breakfast, but by the time she did the 20th patient, it was after breakfast. Now she'd look at that blood sugar, and you get your supplemental insulin. So if your blood sugar is between 12 and 14, give this much extra, and between 15 and 18, this much extra. When a blood sugar is done before the meal, that's great. But if you start eating and don't have insulin, your blood sugars are going to spike. And then the nurse comes and does a blood sugar, and now you're 15. You were 5 before breakfast. You're now 15 because you ate without insulin. Now the nurse comes along and went, oh, you're 15. I'll give you your mealtime insulin plus all the correctional insulin, and you're going to crash. You didn't need correctional insulin before that blood sugar. Blood sugars, it is vital we do it before they eat. If we do them post-meal, it's all going to go wrong. If we give insulin, we have to give insulin before they eat, because otherwise they will go high and then they will come down crashing. So this is logistically hard sometimes, and this is where we need to speak to nursing homes, and we teach kids to inject their parents. We teach parents to inject their kids. I teach teachers how to inject kids. People can inject them. Most of these patients can inject themselves. We just need the dose validated and make sure it's accurate. They've been doing it forever. Not giving insulin at the right time, not doing a blood sugar at the right time gives us so many problems. And this is where you get hypoglycemia and hyperglycemia and DKA. We've got to test before meals. We've got to inject before meals. So diabetes in aged care, it's costly. And it's very, very common. 1 in 4 of your patients have diabetes. And it's expensive, because we call ambulances when they're not necessary. But I get it, you're there and you don't know what else to do. But you need the tools to be able to monitor. Is it a type 1? Do they have ketones? And I'm going to talk about continuous glucose monitoring and all that in another talk later. And hypo is in the next talk. But if you have CGMs, and we give them out for free, we put them on patients and I work out their doses. If they have type 1 diabetes, you need to know, and all your staff need to know, this guy in bed 5 has type 1. He needs to be monitored. We need his food intake monitored. We need him to get his insulin before he eats. And you can never, ever withhold his long-acting insulin. Otherwise, you'll produce ketones. And they need regular endocrine consults. If you have type 1 diabetes, a GP enough is not enough, right? A GP alone is not enough. They must see an endocrinologist. We monitor, because if I want to know how effective that drug was, if I need to know how many units of insulin to give you, I need to know what your blood sugars are. So that's telling me, oh, look, he goes high after breakfast every time. I need to increase his Nova Rapid for breakfast. He goes to bed with a blood sugar of 8 and he wakes up 18. He needs more long-acting insulin overnight. Or is he eating food? Right? And that's the other thing. I when I did the audit, this one gentleman went to bed with a blood sugar of 10 and he woke up with 24. And I went, what the hell happened? And it took a bit of working, but what happened, he had 6 pieces of toast at 2 o'clock in the morning. He's got dementia. He's in his 80s. And 6 pieces of toast sent his blood sugars up to the high 20s, and he was unwell. And And I was trying to explain to the nurses, you can't just feed them. And they said, well, it is right to eat. I said, yeah, but we're causing harm. If that was your dad living with you, you'd be saying, reasoning with them, Dad, it's going to be breakfast in a couple of hours. Let's go to bed. Can I get you some cheese or some water? And then go to bed. We'll eat breakfast. But to give them all that food, because as they're right, we're making them very sick. So just
Excuse me, Irene. We have gone over time.
Yep.
I'm just wondering whether the participants would like to stay on if they have any questions, or understanding that some people may have to leave, and that is fine. And we could possibly hold questions over to next time. If people would be happy to stay on, we can extend by a few minutes. We do understand if people have to leave, you could possibly put your questions in the chat and we could provide those. Irene could provide answers to those.
Yeah. Just make sure you have a monitor dedicated to your service that can check blood glucose and blood ketones. This is the one we use at Nepean Blue Mountains Local Health District because it takes into consideration hematocrit and medications. It reads from 0.6 to 33.3. So if that meter says low, they're probably unconscious. And if it says high, they're very high, right? Questions? Does anyone have questions? Happy to answer them. And there's an evaluation if you can also fill that out, please.
Yes, so if anyone has any questions, feel free to open your microphone and ask Irene. So thank you, Irene. Appreciate your effort in presenting today. It was such an enormous topic, and that is why we have 3 more presentations. And thank you to all those people who have taken the time to complete our evaluation. We do appreciate Irene's contact details. If anyone is interested and wants more information directly from Irene, feel welcome to make contact with her. Thank you for joining us today.
And I'll send you those resources. Like I said, I've got a bunch of them. I mean, we do end of care, but there's a lot. Managing diabetes and aged care, healthy eating for older people. The McKellar guidelines is an amazing for residential aged care. So I've got quite a few of these that I'll send to Anne and Hayden, and you can put them on the website as a resource.
And we'll collect those from Irene, and if anyone is interested in those resources, we can make them available to them. Thank you, Irene, and thank you for joining us today.
Thank you, everyone. Bye-bye.